welcome to Pathagonia. This is Jay. Today we're going to use Kurt's notes to talk about non-neoplastic bone and joint lesions, which can be divided into infectious, degenerative, autoimmune, crystalline, and metabolic. Currently, I'm on my soft tissue rotation, and it's quite hard. So I'm using Kurt's notes to help me out. And if you already haven't been, check out Kurt's notes. It's got great resources for pathology residents, med students, and pathology staff alike. So let's talk about the infectious portions of non-neoplastic bone and joint lesions. Acute osteomyelitis. My institution, we get amputations oftentimes, if not for trauma, osteomyelitis, and we'll sample the ulcer, we'll sample the underlying bone beneath that ulcer, as well as the surgical margins. And microscopically, we will see this kind of acute inflammation. We'll see neutrophils within the trabeculae. We'll see necrotic bone, as we can tell with these empty osteocyte lacunae, and then we'll see these kind of moth-eaten, rat-bitten / scalloping appearance of the trabeculae. And it's often caused by bacteria, usually staph species, and you can get this from hematogenous spread, which is primary, and often in kids in the metaphysis of long bones or adults in spine. And it can also be from direct inoculation, often from trauma or ulceration. Then you can get chronic osteomyelitis. You won't see those neutrophils in the trabeculae. You'll see chronic inflammation with bone destruction and remodeling. The marrow can be replaced by fibrosis with plasma cells and lymphocytes. You'll see bone remodeling oftentimes with osteoclasts, which are multinucleated cells and that break down bone, and osteoblasts, which can appear plasmacytoid and they build bone. Plasma cells are polytypic to differentiate from plasma cell myeloma, which would be monoclonal. And you'll often see that irregular rat, moth-eaten, and scalloping appearance, but you won't see the neutrophils within the trabeculae. And you can see granulation tissue. If you do see necrotizing granulomas and it's in the spine, you can consider Pott's disease, which is tuberculosis in the spine. And it's important to know that you can have sinus tract to the surface lined by squamous epithelium. And if constantly inflamed, that could be a risk factor for squamous cell carcinoma transformation. And here's a little cute mouse kind of trying to take a bite. Septic arthritis. This is an acute medical emergency that needs rapid treatment. You'll see neutrophilic inflammation of synovium with pus in the joint space. It's often a clinical lab diagnosis, and it's often caused by bacteria such as staph epidermidis, especially because they can form biofilms on the prosthetic joints. Periprosthetic joint infections can be sent as a frozen, especially if they're concerned for infection, because that can cause prosthetic loosening and requiring revision. And if they do send a frozen of the joint capsule, your threshold for calling it is greater than 5 neutrophils per single high power field in 5 separate high power fields, excluding surface fibrin, which oftentimes does have acute neutrophils. And you want to make sure it is indeed neutrophils, because this is a frozen and it's not as good quality as your H&E that's been processed overnight, because lymphocytes can be twisted and mimic PMNs. And you don't want to call the lymphocytes neutrophils, because then the surgeons will remove the prosthesis and subsequent reimplantation after eradicating the infection. Some ancillary studies besides microscopy is physical exam, cultures. You'll have elevated ESR, CRP, and synovial fluid studies. All right, let's talk about degenerative reparative changes. DJD, osteoarthritis. This is non-inflammatory loss of the joint cartilage. You'll have this eburnated bone surface. It'll be worn, smooth bone surface. You'll have subchondral bone sclerosis. You'll have periarticular bone cysts, as you can see here, geodes. You'll have osteophyte formation and synoviocyte hypertrophy and hyperplasia. Etiologies include trauma, wear and tear. If you get your ACL torn and you don't get reparative surgery, it could accelerate into DJD. Metabolic disease, avascular bone necrosis, and altered loading or anatomy, such as kind of like a leg length discrepancy. If treated surgically, you can do a joint, like could do like a hip replacement, for instance. Ganglion cyst, this is kind of a bone soft tissue derm path overlap. It's cysts composed of fibrous tissue without a lining, without a true lining. So it's not really a cyst, more like a pseudocyst. It contains myxoid mucous material, can be unilocular or multilocular. It seems to arise from the joint capsule and most often on the wrists and hands, feet, and common in young adults. If bothersome, you can remove it surgically, and they used to call this a Bible bump because historically you can strike and rupture this with a large heavy book like the Bible. I did not know that, and that's pretty good historical nugget. Okay, let's talk about fracture callus. This means a reparative change seen at a site of prior bone fracture, and immediately after the fracture, your blood vessels at that site are going to rupture. So you'll have hemorrhage, you'll have hematoma, and then it'll gradually be replaced by organization with granulation tissue. You'll have this woven bone, as you can see here. You can see some granulation tissue and onset of fibrosis, and cartilage with ossification. You'll see this prominent osteoblastic rimming because it's building bone and bone remodeling. On imaging, you can see the prior fracture. You should not see atypical mites or significant cytologic pleomorphism. Otherwise, you might be concerned for like an osteosarcoma or a chondrosarcoma, depending on what component is atypical. Avascular necrosis. This is geographic area of subchondral bone and marrow necrosis with partially separated articular cartilage surface, this crescent sign, as you can see here. I remember learning this a lot. It was honed in from medical school, but the risk factors are trauma, steroids, alcohol, chemotherapy, collagen vascular disease, pregnancy, and I believe like sickle cell disease in kids too. And if you do have this, it can lead to accelerated DJD and osteoarthritis, which would require a joint replacement. And here you can see marrow and bone necrosis. And you can see the lacunae, there are no cells in there. Okay, you have aseptic joint loosening. This is when foreign materials from your prosthetic where has these particles that come off, and you'll see those fragments. They can be metal, polyethylene glycol, cement, ceramic, and your macrophages are your kind of garbage cleaners, and they'll ingest it. And this can cause inflammation around joint, lead to a little bit of bone loss, and then that can lead to joint loosening because it's not tight anymore. And then histologically, you'll see foreign body giant cells, those foamy histiocytes with the engorged inorganic particles. And then if you see wear particles from metal articular surfaces, those generally are small and appear black, and it can accumulate, and it's called metallosis. And it's fascinating how foreign particles can make their way to regional lymph nodes. Metal can do this, tattoos can do this as well. All right, AVAL, aseptic lymphocytic vasculitis associated lesion. This is seen with metal on metal articulations. And despite the names, such as like a ganglion cyst, without it being a true cyst, this also is not a true vasculitis. Excuse me. Because vasculitis, you would see fibrinoid necrosis, extravasated reds, karyorectic debris, lymphoplasmacytic infiltrate, but there's no fibrinoid necrosis or no karyorectic debris here. The three defining features are these prominent lymphoid aggregates, often near venules, absence of obvious metal debris, and necrosis of synovium. Loose bodies. So these are loose fragments of tissue found within the joint space. Can result from trauma, DJD, or neoplasm, and it's most common in the knee, causing this locking and pain. And you'll see these, grossly they resemble rice grains, as you can see here, and consist of laminated fibrin. And so they're called fibrinous loose bodies or rice bodies. You can see osteochondral or cartilaginous loose bodies, and these are detached fragments of articular cartilage and bone, not of laminated fibrin. And this results from trauma and is often solitary. And then in your differential, you'll want to think about synovial chondromatosis, which is a locally aggressive neoplasm. You'll have multiple hyaline cartilage nodules within the synovium or loosened joint space. The chondrocytes can cluster together in groups, and molecularly it's an FN1 ACVR2A fusion. All right, we talked about degenerative, we talked about infectious. Let's talk about autoimmune disease. Rheumatoid arthritis. This is the most common primary inflammatory arthropathy. It's a chronic, idiopathic, erosive, symmetric polyarthropathy. It can impact all joints, but worst impacted are small joints of hands, your MCPs and PIPs, your feet and C-spine. And then you can have many extra articular manifestations like lung disease. You can get a pleural effusion from it. In the serology, you'll have positive rheumatoid factor, and then I think you have like your anti-citrullonated peptide 1 as well. So chronic synovitis within rheumatoid arthritis, your key things is you'll see this expanded synovium, and you'll often see these lymphoid bodies with plus or minus germinal centers. And if you see that, you really want to think about RA if they don't have a prior diagnosis of it. You'll see this hyperplastic synovium with surface fibrin and fibrinoid necrosis and granulation tissue as well, and it may erode nearby bone. Pannus, this is synovium that erodes cartilage and other joint structures. You'll see this characteristic marginal erosions of bone on X-ray. And your rheumatoid nodule, you'll see this necrotizing granulomas with central you'll see these granulomas with central necrobiosis. So it looks like necrosis here. Your differential is granuloma annulare, infection, and epithelioid sarcoma. So especially if it's a younger patient. Granuloma annulare, you'll learn in DermPath, it's more, or you have learned in DermPath, it's more of like a bluish kind of nodule, or especially that necrobiosis will look bluer. And yes, always have that differential in mind, epithelioid sarcoma, and molecularly it will have an INI1 loss. All right, crystalline diseases can be divided basically into gout, pseudo-gout, and tumoral calcinosis. And I'll have this chart just kind of for you to review. Gout will be this kind of fluffy pink surrounding tissue from low power. It's a uric acid metabolic disorder. You'll get hyperuricemia, and then the crystals will be monosodium urate crystals in the joint fluid and tissues. Classically in the middle-aged males, and the most common joint is the first MTP, but it can occur anywhere. It's important to note that urate dissolves in water during the staining process, so you might often not see it on H&E slides. An option is to use alcohol instead of water, or fresh touch preps. You'll have these needle-shaped yellow, negatively birefringent crystals and the joint fluid will often be neutrophil rich, and these fluffy pink deposits with associated granulomatous inflammation and surrounding giant cells around that the periphery. That's your telltale clue that this can be gout. And if it's in soft tissue deposits, it's called tophi. You have gout, but then you also have pseudo-gout, which is calcium pyrophosphate dihydrate deposits in the cartilage and joint soft tissue. They're darker than your gout crystals. They appear as rhomboidal, and on each knee, you'll see this well-demarcated basophilic material with no inflammatory response, often associated with DJD, and often incidental finding in arthroplasty findings. Sorry about that. And then lastly, you have your tumoral calcinosis. Now, these crystals are made of calcium hydroxyapatite deposits. Since it's Thanksgiving, I do have an appetite. I would have like if I had a drum, I'd be anyway. You'll have common locations are shoulder sites of pressure, and it can be localized in relation to trauma or like a systemic disorder like renal failure or hyperphosphatemia. And you'll see these lobules of these dark appetite type calcifications surrounded by chronic inflammation with a prominent foreign body giant cell reaction. It kind of reminds me of the crystals, and I think it is the same crystals if I'm not mistaken, from if you get a breast biopsy and they see crystals, and it's not the clear crystals, not the calcium oxalate crystals. I mean, okay, we're almost there. Thanks for bearing with me. We're going to talk about the last category, metabolic, endocrine, idiopathic. So Paget's disease. This is a localized disorder of bone remodeling, and you'll have excess bone synthesis and resorption. The early stage, you'll have more resorptive, so the osteoclasts are more activated. And the late stage, you'll have more synthesis, where the osteoblasts are more activated. It's often localized to a single bone in elderly men, and it's important to remember osteoclasts are these multinucleated cells, and then the osteoblasts, you can have rimming, and they can often appear plasmacytoid. You'll have unusually large osteoclasts with increased nuclei and prominent nucleoli. You can see prominent osteoblast rimming. You can see paratrabecular marrow fibrosis, and you'll see these unusually thick and thin bone trabeculae that look like jigsaw puzzle pieces. You'll see numerous irregular reversal cement lines and bone scalloping and a mosaic pattern. The etiology is poorly understood, but it can increase your risk for osteosarcoma. Brown tumor of hyperparathyroidism. This forms a mass-like lesion, and it's most common in the craniofacial region like the mandible and maxilla. And hyperparathyroidism will lead to proliferation of osteoclasts, as you can see here, with fibrous tissue and hemorrhage. And so knowing the history of hyperparathyroidism is key. And you can treat this with parathyroidectomy. And then it's important to know that PTH, because your differentials include giant cell rich lesions like reparative granuloma. And you can also see generalized bone changes with cortical bone loss, and that can lead to ascites fibrosa cystica. Osteoporosis is decrease in mass of mineralized bone, which can increase your risk of fracture. It's frequent in postmenopausal women due to estrogen loss and with aging. And it could also be secondary due to hyperparathyroidism, malnutrition, and medications like steroids. And then renal osteodystrophy. This is seen in the setting of chronic renal failure. It leads to increased osteoclast activity, and because you're consuming more bone, this leads to osteoporosis. You'll have these kind of wavy, very thin, bony trabeculi. And with renal failure, you'll have hyperphosphatemia, secondary hyperparathyroidism, and increased osteoclast activity. And then Also, vitamin D deficiency will lead to hypocalcemia, which will lead to decreased ability to generate bone. All right, thank you for watching Pathagonia. We really appreciate it. Again, just to overview, bird's eye view summary, we have non-neoplastic bone and joint lesions. It can be divided into infectious, acute, chronic, osteo with septic arthritis and periprosthetic joint infection, which you can be called in for a frozen. We have your degenerative reparative changes, osteoarthritis. You can have a ganglion cyst. It's not really a cyst because it has no lining. Fracture callus, avascular necrosis, aseptic joint loosening, and aseptic lymphocytic vasculitis associated lesion, AVAL, which is not truly avasculitis. And your loose bodies, which can be fibrin or fibrinous loose bodies. It can be osteochondral or cartilaginous loose bodies or synovial chondromatosis. Talked about your autoimmune diseases, rheumatoid arthritis. For your synovium, you want to be suspicious if you especially see lymphoid aggregates. And pannus and rheumatoid nodule, which the necrobiosis will look pink. Granuloma annulare, in contrast, will look blue. And then you always want to have your differential of epithelioid sarcoma. We talked about crystalline diseases, gout, pseudogout, and tumoral calcinosis. Gout will be due to monosodium urate crystals, and they will be yellow, negatively birefringent. Pseudogout is calcium pyrophosphate dihydrate, CPPD crystals, and they're darker than your urate crystals. And then tumoral calcinosis, calcium hydroxyapatite. Then lastly, metabolic, endocrine, or idiopathic. Paget's disease, you can have an increased risk of osteosarcoma. Brown tumor of hyperparathyroidism, you really want to nail that history of hyperparathyroidism. Osteoporosis and renal osteodystrophy, which is in the setting of chronic renal failure and increased osteoclast activity. Well, thank you so much again. Happy Thanksgiving, and we'll see you next time. Bye.